Can you guys hear me? All right, it's about 8 o'clock. I'm Sarah, I'm a CRNA here. I just wanted to talk a little bit about trauma initially, and I sort of took it in a different direction. Thank you for having me. And I have a lot of slides. I'll try to go through them as quickly as possible because I know we all have cases to start. And I want to just say Laura Beth Fenton is here from emergency management. My goal is kind of try to get us as a department in the OR more involved in hospital emergency management if there was to be a big mass casualty. So she's kind of the expert at that. So more to come there. Yeah.
You need to talk kind of back and forth because I can give you a hand mic. Okay, very good.
All right. So I have no financial disclosures. I'm required to say that. However, feed is $30 a bag. So if you would like me to have financial disclosures, I will take donations from my goats and my chickens. My chickens are dairy chickens. They are not meat chickens. Somebody around my department thought that eggs were dairy, so I thought that was very funny. Anyway, so just a quick overview of what I'm going to talk about. Various mass casualties around the world and hospital responses to that, challenges that they experienced, lessons that they learned, sort of looking back and then looking forward, and then how that relates to anesthesia. So I've done a couple trips to Israel to learn disaster management, trauma management, mass casualty management. Most recently, I took a group from UVA. There's Val, she's the director of trauma at UVA. She came with me this last time. Dusty, Mike Berg, he's Virginia EMS with the head of Israel's EMS there. We did real mass casualty, well, fake mass casualty training, some stuff there. Intubation with VR in like a battle scene. And then in the middle there, if you see the person at the top, if you aren't trained, if we don't take our place as anesthesia providers, he's an orthopedic surgeon. I really don't think we want people, orthopedic surgeons taking our place. And then we did search and rescue for like earthquakes and stuff. So that's me with the chainsaw. So just a very quick review of different mass casualties that have happened sort of in the last 10 years around the world. Bastille Day in France, 2016, a terrorist drove his truck through a big parade at night. 86 people were killed, 10 of them children, and 458 were injured. Not to mention the psychological trauma. 2017 in England, in Manchester, it was in the Ariana Grande. I don't know her, but apparently she's a very popular singer. She was doing a concert and a terrorist came out to the entrance exit of the place where they're having the singing, the concert, and he blew up a dirty bomb with nails, killed 22 people, 10 of them children, but over 1,000 were injured. Most recently in Israel, 2023, 6:30 in the morning on a holiday, 3,000 terrorists came over, killed 1,200, 9,000 were wounded, hostages were taken. One of the biggest challenges with this is that it wasn't one location like the two previous, it was actually 600 locations throughout the country, and unfortunately hospitals and ambulances were specifically targeted. One hospital in the south, which I'm familiar with, Soroka, they took 700 patients within 12 hours. So imagine 700 patients coming to our ER. So that was the largest mass casualty ever in a single day. This is a picture I took when I was there. This is a very small demonstration of the trauma that happened. These are all the cars of people who were killed and burned alive inside of them. And then this is a few years back, 1995, but I wanted to sort of mention this is a different sort of MCI event in Japan where 3 terrorists, I guess, went on a subway. They had a bag of liquid sarin, popped a hole in it and ran. And so sarin gas killed 13 people immediately, but look how many people are injured. Injuries mean they have to come to the hospital, and those are the ones that we have to deal with, right? And then just looking throughout the globe, Nigeria, this is ongoing today. Just last weekend, a big massacre happened, 50 people killed inside of a church. And then there's Ukraine. That war has been going for how long? Those hospitals have been dealing with trauma and mass casualty for years, and they're getting very tired. They have a lot to share with us. This one kind of hit me. There was a direct attack, missile attack on a children's hospital. in Ukraine, and those are pictures from that attack. And then there's current. Right now, we're at war in Iran. But we tend to do this. It's over there. It's not over here. So why do we care? So just a very quick review of mass casualty events since 2015. And I'm just going to talk about two of them because I had the fortunate ability to attend this conference with our country's uniformed services, where the people who responded to those attacks actually gave us the presentation. So in 2017, I don't know if you guys remember, it feels like yesterday, but when there was a country music festival, a terrorist went up to the top of a building, a hotel, and he took an AK-47, 1,000 rounds in 10 minutes, and just massacred people. So immediately, 61 people were killed, 400 people were directly injured, but that created such mass chaos that over 800 actually were injured, because you don't just get injured from the actual event. You're running, you hit your head, you hit your ankle, actual panic. And this was a very challenging event because 80% of the injured people did not come to the hospitals via EMS. They just arrived. Some not conscious, some having a panic attack. So identifying them, triaging was very difficult. And a lot of them were from out of town. So you had two hospitals responding. And the presentation that I went to was from the level 2 trauma center, Sunrise Hospital. She gave us this very good talk about it. They're a very small hospital. They became immediately overwhelmed with 200 casualties right away in their ER, and they had to just triage them sort of all over the hospital, in the lobby and such. And they, of course, had to treat the patients, but why are they, as a trauma 2 center, doing the majority of the trauma work when just across down the road, not very far, is a level 1 trauma center, much more able to handle the casualty load, but they weren't getting the patients. Well, the people at the Trauma 2 Center thought, well, they must be completely overwhelmed and we're just taking their overflow. There was no communication between the two hospitals, even though it was an inappropriate sort of response, and people were just sort of bringing themselves to the Trauma 2 Center. So 200 casualties around with gunshot wounds, penetrating trauma that came in. Within the first 24 hours, 88 surgeries. That's a lot. Think about if we had to handle that. Then the next one that we talked to, that you can barely see her picture down there, Megan, she's an amazing person. She's the EMS director. 2025, January 1, I don't know if you guys remember, there was a terror attack. It was like 2 or 3 a.m. And what happened is a terrorist got into a truck. He drove down the Bourbon Street and just acted like a drunk driver and just sort of hit people, killed 14 people right away, and ended up, you see at the top, he ended up hitting some sort of construction lift, and they said they don't even know why that was there. He hit it, and that's what stopped him. So she responded. You know, you start triaging people on the scene, dead, about to die, alive, walking, wounded, etc., treating everybody. And then she got to that truck, and she thought he was a drunk driver, so she was about to start delivering him treatment, and the police jumped her and pulled her back and said, no, he's a terrorist, and they had shot him in the head, and in his hand was a detonator for an IED. So his plan was to do this, and then see at the bottom there's cooler. He had put bombs inside those coolers. It was, you know, people were drinking, and they thought that was drinks. They even saw videos of people hollowing those around. There were bombs, and his intent was to have the EMS to come in and then to hit the IED. So there's a lot of good things that happened where not so many people were killed. Unfortunately, 14 were, and about 60 were injured. So looking back at all of those from around the world, including in our country, what were the lessons that they all sort of shared? Was they had a plan, an MCI plan, but really didn't account for the large amount of patients. They thought maybe 5, 10, but they weren't prepared for 50 to 700 patients coming. And then really didn't consider like registering and identifying patients when they come, not through an EMS or not triage. They don't know what sort of treatment they've got. They've got no treatment. So non-conventional patient arrival to your ER is a real thing. And then 15 to 20% of patients in a disaster are typically pediatrics. and they tend to be a little bit overlooked, and they have their own, obviously, their own issues. Like I said, identifying them and then registering them. Do you register them on paper? Do you register them on electronic? Do you register them both? Do you say, oh, we're at 20, now we're going to switch to paper? This was a big thing. Some people complained about the EMR because it was not easy to, how it is, IT, the buttons, and you have to go here and here, it's not working. People who did the papers lost the paper, it got spilled on, they got ripped on. So, there was a big challenging thing with that. I liked this quote: the hospital had no system to send out a mass alert to the staff other than an old phone log. And that was from the Las Vegas lessons learned. Communication, they couldn't use their cell phones. They had no cell reception, so they were using Facebook Messenger. And between Israel, Manchester, France, and even Las Vegas, a lot of them resorted to WhatsApp. That tended to be the best way to communicate, not because it's private and encryption, but it just had the best reception. And then resources. Blood was a huge one, mobilizing the blood. They weren't prepared with the amount of blood that they had. I don't know if I didn't point out, but in Las Vegas, they used 88 units of blood immediately. So they didn't have enough. They had to pull from other hospitals. And then just the actual capacity of where you're putting people who are already here and then bringing in the people who are coming. Pyxis was an issue. You have to have a patient ID to get into Pyxis to get drugs to treat them. So in the Las Vegas attack, what they did is pharmacy just ran around the hospital, unlocked all the Pyxis, and just let free flow, pull out, because they had to in order to. And then the surgical workload was not expected. They weren't prepared for it. So looking forward, how do we prepare for such events? Obviously, having a plan is great. But if you don't know what your plan is and you don't know what your role is in that plan, it's really completely useless because it sits away. So I'm going to ask yourself, do you guys know what our MCI plan is? Do you know what your role is? If you got called to the ER, would you know what to do? So these are things that I would like us to engage in. When you drill, you actually have to include everybody who is going to be involved in that drill. And if somebody gets shot, they do actually go to the OR. So maybe we should be involved in that. And then to actually scale your drills and your protocols to meet the actual number of patients that you might need. And you might have a different response for 50 patients than you would for 500. So what's your trigger? Are you going to use the staff that you have, the resources you have for maybe 10, 20 patients? But if you have 500, you're going to have to almost have a completely different plan. So keep it updated. And this picture here, I took from an article where they did a drill, and what they did is they took a ton of patient cards, they made patient injuries on it with pictures, and then they took that patient all the way through the hospital, changed the pictures, changed the diagnosis on the card, assigned them to, like you see in anesthesia, this is the OR, an ER, an anesthesia resident, all the staff there assigned to that patient, they're changing it, and they made it so that it was reflected time. So you didn't just sit there within a 2-hour drill and say, okay, this and this and this. They actually took this patient, did the imaging with it, changed the diagnosis, and moved it on and on and on, and then went back and assessed and measured what resources they did and did not have. So I liked that. So measuring your capacity and resources, just kind of like I said, pretty much they say normal preparedness for mass casualty, you expect to absorb about 20% of your existing. They said that's not enough. You need to say 50% or more. And you need to measure your assets from the beginning all the way to the end, not just the ER, not just the ICU. You need to include everybody to assess. And you might have the capacity, the ER might have the capacity to handle that many patients. Does the OR? And if the OR has that capacity, does the ICU have to keep on looking downstream and saying, where's the bottleneck going to happen? Because if you don't measure it, you're never going to improve it. Documentation, I mentioned that. This is a picture I took when we were in Israel in the ER. They have their trauma bays, one huge room set up. They have a cot. On the cot is a pre-mounted monitor, is a pre-mounted ventilator. So the patient comes into the room, comes onto the bed, and the chart is sitting right there at the end of the bed. Sorry. It's all paper. Everything's ready to go. And then if they need to be transported, guess what? You don't have to get a monitor or a ventilator or an ambu bag. Everything's right there. You just go. So you kind of set up. So whatever method you choose in terms of documentation, practice it and find out what does and does not work. Communication, like I said, it was a big issue, not just between staff, but also between the ER and the ICU and the OR, but also hospital, as we saw with Sunnyside in Las Vegas. The one hospital just assumed the other hospital was overwhelmed. The trauma 2 thought trauma 1 was overwhelmed and didn't communicate with them. Had they communicated, they probably could have done a little bit more triage. And having a staff recall, our communication, we're working on it. I have to say, boy, Sarah is not my friend on a daily basis. So basically, all these things taught us communication, supplies, and then about the emotional toll, and I'll talk a little bit about that. So backing up, we talked about MCIs that have happened. What actually is an MCI, mass casualty incident? Is it a specific number of people? Is it the type of disaster that happens, some sort of tragedy? No. It's when it can be dependent on the hospital. It's when all your existing resources have been overwhelmed and you need to go beyond normal protocols and change something and go into like emergency mode. And unfortunately, you can't say, so we can look back and say, okay, they had 50 injured, they had 70 injured, great, so you can plan for that. No, when those events are happening, like the one they had in Israel, they thought that was the end. They thought that their country was now destroyed. They didn't know that in 12 hours that event was going to end. So if we had, a fire drill happen or whatever, it happens, you start dealing with it. You have no idea if this is the beginning, if this is the end, if you're going to get another 100 patients. So you're trying to save resources, but how do you save resources when you're not looking back? You have no idea what the future holds. And maybe you're being under attack. So the principles of managing a mass casualty, obviously triaging. And instead of operating like we do, you have your one trauma patient, you're going to do everything you can for that one trauma patient. Instead, now you have to sort of look beyond that and say, I need to save as many people as I possibly can. And if this person isn't really in the situation that they're going to survive despite what I do, you might have to say, I'm sorry, and do the palliative care thing with somebody and choose who might die. One-way patient flow, so they're going to come to the ER and go through all their destination points, but so that if they came to the ER and they go to imaging, they're not going to come back to the ER. They're going to completely continue to go. So that's why you need to have somebody be able to manage that flow. So I put a little picture in there. So their first assessment, first triage, can they walk? Can they wave their hand? Are they lying completely flat? That's your first sort of triage. So the ones who are still, they probably have a life-threatening injury. So they're going to be ones who you look at first. Then you bring them down. Are they breathing? No. Then you might say, okay, I'm sorry, you're dead. And yes, they are breathing. You can go down. Do they have a pulse? Can they follow commands? Are they in distress? And then from there you triage. As the little graph says, yes, they are moving. They can talk. They probably have minor injuries. So maybe they can be triaged to another area with like walking wounded. If they're not able to respond and they do have major hemorrhaging, so then they're going to be immediate. And unfortunately, that immediate is in green. It should be red. They're like the kind of patient that's going to come to the OR. And if they're not likely to survive, even with a little bit of help, then they're going to be considered expectant, which is dead. So expectant, black, is they're going to pass away and maybe just give some pain control and palliative care. Immediate is the red, which they need life-saving emergency now. Delayed, yes, they might have life-threatening injuries, but they can probably have a little bit of time before they need treatment. And then minor is green, it's not so bad. And this needs to be a continuous reassessment because they can change. So what does anesthesia have to do with it? I personally think, as Beth knows, I think we have a lot to do with it. And I think that as anesthesia providers, we are so well suited to handle disasters, because guess what you do every single day when you're working with a surgeon? You're like saving them from the surgeon who's causing major disaster on a patient. You know how to plan ahead. You know a plan A, a plan B, a plan C. I know if I'm going to plan a MAC, well, what if my MAC doesn't work or sedation doesn't work? If I'm going to do an LMA, well, maybe my LMA, you always have a backup plan to what you're doing. You're hoping for the best, you're expecting the worst, and what do you set up on your Pyxis when you do any case? You set up your emergency drugs. You're always prepared for an emergency. You're prepared and you're thinking about worst case outcome. Beyond that, and I liked this quote, anesthesia providers have the brain of an intensivist, the hands of a surgeon, and the heart of a psychiatrist. You know, it's a pretty good package. You can handle pediatric to geriatric. You can work all over the hospital, not just the OR. You're in the ICUs, you're in the wards, cath lab, IR. You talk to pharmacy, you talk to blood bank, you do imaging, MRI, CT. There, airways up in the ICU. There's so many places that you go, so many people you talk to. Assessment skills are very quick. You don't have to go through. I mean, you look at a patient and you know sick and not sick very, very quickly. Airway skills, top notch. Constantly resuscitating, blood, crystalloid, albumin, you know these things. Pharmacology, it's the only profession where you can say, I need this drug, dispense it and give it and assess it and redo it. No other profession can do that. Critical care skills, pain management, ultrasound, POCUS, all those things, amazing. But we're not involved in actual disaster management. And so I picked this slide because I thought, when I looked at it, I said, you, top of the mountain, smartest person ever. And then I realized that it's actually the opposite. So Einstein's the smart one over there, and apparently Chris Langhan, whoever he is also very smart, and you is in like the dumb crowd of people. But being dyslexic, I saw it the other way around. So I'll put you with Einstein and Chris down there. Okay, very smart and very good, but are you prepared for a mass casualty? If you look at the Boston bombing in 2013, which I know everybody is familiar with that, which was like the perfectly responded mass casualty event because everybody had practiced it between EMS and hospital. Explosion was at 10 to 3. The first patient in the OR within 45 minutes. So imagine an explosion in Charlottesville, and now in 45 minutes, you have to be in the OR and prepared. You're getting the red patients. You're not getting the ones where you say, oh, they may or may not come. Here's your injuries. No, go now. Are we prepared for that? So in this paper, why we must train, prepare, and be at the forefront for disasters and mass casualties. They did a review, and they pretty much found that most hospitals and most physicians actually lack understanding of how to respond to a mass casualty. Anesthesia in specific was overlooked by ourselves and by hospitals in general. When there was hospital management looking at either penetrating trauma or active shooter events, they reviewed all the stakeholders, but anesthesia was rarely to never included. And then even if you look at our own literature, EM medicine does tons of disaster management. Let's be prepared, because they're the first ones who are going to be prepared. We don't look at it ourselves because we don't include ourselves in that. And then education, there's been many statements put out by state, academic, AAMA, there's a whole bunch, letters, whatever. Anyway, education in residency, in CRNA school, whatever. And even when you come to your institution, how many of you learned disaster management in med school? Some, a little, maybe. Efficiently? Continued? I don't know. So they did this one paper and they said, let's test and see if anesthesiologists would actually respond. So they sent out an alert. Half of them didn't respond because they weren't prepared to. Phones weren't turned off and they didn't know what the mass alert was. So basically they said at the minimum, every anesthesia department should have a method of mass recall and to test that system so we actually would know what it was when we got one. So we have this thing, it's called Brave. You guys get it, UVA alerts. And I was wanting to test it today, but we have a little bit of IT work to do on it. But in the future, I think I've sent out a few emails about it in the past and more to come on that. but it's kind of like what you would get from your UVA alerts. But it will say, mass casualty event has happened. Can you respond? And you'll give you 4 options. I'm on the unit. I cannot respond. I can respond in 3 hours, 2 hours, or 4 hours. And then you just answer that. That's it. It's not a back and forth communication. It's not telling you that you have to come in, but it gives us data to figure out what our resources are, and then we can make a staffing plan from that. So a little bit more to come on that, but I wanted to mention that. So what sort of big overview, what would happen? What would our response be? So an MCI happens, it's assessed by emergency management, the ER, they decide whether to call a mass casualty event or not, and then you follow your plan. But this becomes our problem because we don't actually have one at UVA to come. And then there's communication between incident command, the ER, they call us, they work out, this is how many casualties. At that point, if we think that there's an MCI, we probably should consider canceling elective cases. It will be the red patients that come to the OR in a major mass casualty event, not the one who needs surgery, just needs surgery. No, the one that needs to come to the OR in order to live. And so those are the ones that, how much time do you have to prepare your OR for? Not very much. How much time do you have to figure out how to be a good anesthesia provider in providing trauma? Now, it doesn't matter if you're a CA0, a CA1, or a senior. If you have a mass casualty event, all of us need to know how to respond to trauma anesthesia. This is very hard to read, and it is from the ASA. It is the ASA mass casualty checklist. I don't know if anybody has, it took me I tried, I begged to become a member of the ASA just to get this. I was denied. Somebody else got it for me, but there's a lot of good stuff on there, so check out your own website. Anyway, it has everything on there, and I think it's very good, and I think that I would like to sort of adopt this into UVA, but just to, if you can't read it, I'll just quickly go over it. Basically, follow your own plan at your own institution, activate your call tree, assess the status of all your ORs, alert your current ORs, assign staff to all those ORs. The board runner will become the medical director for the OR. Good. Then you have to communicate with OR, with the ER, with incident command. You have to ensure you have adequate supplies. How many times do we have not enough like PDM or a monitor or like the pumps? Yesterday I spent 20 minutes to try to get my pumps to work because they all needed maintenance. Those things can be frustrating. And in a mass casualty situation, you actually might have to do old style anesthesia, like the drip line 15. When I was a nurse in Canada, we didn't have pumps. We did just the drip for everything. Welcome to socialized healthcare, because nothing's changed. Anyway, also, you might need to send a group of anesthesia and nurses to the OR and provide trauma anesthesia and care there, because like I said, you have emergency resuscitation skills, you have airway skills, you have procedural skills, and they might need help. Hazardous or hazmat event. How many here would feel comfortable responding to a nerve gas attack? One. Would you feel comfortable touching the patient? What if they're exposed to radiation? Organophosphate poisoning? How many feel comfortable? I wouldn't. So personally, I want that training, and that's where Beth is going to help us. Not today, in the future. But we're supposed to have a plan. That's in the ASA. We're supposed to know these things as anesthesia providers. I mean, that's neostigmine, succinylcholine. These are our drugs. These are very much related to nerve gas. The pharmacology, the chemistry is something that you would be very and are very good at. So if you want to save the masses, start with one. This is a thing in Judaism. If you save one life, you have saved the whole world. One life is so important. So you start with damage control. ABC begins with X. X is not just bleeding. X is exsanguination. So you are not just saying, oh, I have a cut. I'm gonna take care of the cut before I take care of the airway. No, it's massive hemorrhage that is life-threatening. That's what you're gonna take care of first, and then you're gonna go down your ABC thing. So if somebody is unconscious because they're bleeding to death, well, giving them oxygen, intubating is not probably your priority. It's gonna be stopping the bleeding. Can you guys hear me if I walk up? Okay, just a small test. In the whole concept of stopping the bleeding, you're going to be my victim. I cut my arm off because I'm really good at a chainsaw, but I wasn't one day, and I cut off my arm. You happen to have a tourniquet in your hand. Save my life if I say I cut my arm here. How do you know? So how he says it's not probably tight enough. How do you know if it's tight enough?
Bleeding stops.
Very good. Exactly. So the bleeding stuff. Well, that's step one. Now step two.
You to pick the med student.
Yes. You're the closest one. I didn't want to walk all the way up. Med students are great. Very good. Uh-huh. Two more steps. Very easy. You can figure it out. You did it. Almost. So just take this and put it there and then that. Okay. Did you guys see that? Very simple. Yeah, you can applause. So tight. And then, so if I was to do this on myself, I like how you put it on because I could grab it and I can pull it tight to myself. So it's a self-administered thing too. And then you're going to take the windlass and tighten. Stick it in. And why do you want the white piece over? What's on that? Time. Do you always carry a Sharpie in your pocket? Because you always carry a tourniquet in your pocket, so. What can you use to write time on there? Blood. Might be a little bit messy, but it is important. Very good, thank you. Do you guys know differences in color? So if it's orange, it's civilian. If it's camouflage, it's usually military. And if it's blue, then it's training. Fun fact. We're not going to do wound packing because I don't want to be the victim of that. But, and I'm not doing stop the bleed right now. Tomorrow, if you guys are interested, I'll do a little stop the bleed thing. But basically, you're stopping the bleed by putting the tourniquet on. And, you know, tourniquets kind of got a bad rap for a little while because the arm, well, what do you want to die, my arm or my body or myself? I think I'll take my life over my arm. If you cannot, and if you had a head blood bleeding, you don't put the tourniquet here. I asked just to see what the response would be. Anyway, torso, then you're going to do packing. And if you're in the field, if you're outside and you're not carrying anything, you can use your clothes or whatever and you pack it into the wound until it stops. So that's damage control, resuscitation. So the patient comes to you and you need to resuscitate them. You're going to resuscitate them with what they lost. So a good saying in Israel is like, so if they're bleeding normal saline, go ahead and replace with normal saline. If they're bleeding blood, replace blood. Filling the tank with saline when they're bleeding blood only causes damage. You're causing more bleeding, diluting out what you already have, acid-base imbalances, and it's bad. You do your MTP, and I'll have a slide here in a minute, your MTP protocol. In that, when you're replacing blood, you want to make sure you're replacing calcium chloride with that. TXA is also on the list. I think you guys know that. And keeping your patient warm is very, very critical. This is from our website. I'm not going to go through it. It's actually on I took it straight from our desktop in our OR under transfusion protocols. It's in there. The difference between fast blood and MTP, when to call for it, what do you get? Basically, fast blood is like not quite at an MTP level. Maybe they only last about 750. You're not going to get all the same products. You're only going to get 3 plasma and 3 blood, red cells, and it won't be reoccurring. So if you need real resuscitation reoccurring every 15 minutes, new cooler, then you need to call an MTP, and that's going to give you the 1-to-1 ratio. Airway, because we're anesthesia providers, that's our favoriteest thing ever, but I want you to look at this little thing. So this is not the exact patient, but there was a soldier who was shot in the neck, and he had bubbles coming from his trachea and esophagus. Ooh, it's going to be a fun intubation from us. But they did not intubate, and they saved his life because they did not intubate. You sit them up. Who cares about C-spine, all this? You sit them up so they can breathe. What do you do when you can't breathe? You sit up, right? Give him oxygen and leave him. If you lay him down and paralyze him, give him drugs, and now you have a difficult airway and you're not in the OR, you'll most likely kill him. Not even just because the airway is difficult, but the drugs that you give him will compromise his life because he's in a state of shock. So anyway, the paramedics who responded to this were given huge accolades because they saved his life by not trying to be heroes themselves. Don't forget, I took this one point from one of the paramedics. He's a military medic and civilian medic. He has dealt with many, 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 many injured trauma patients, and he said, don't forget to treat the pain. I was a flight nurse here for a long time, and I was taught, don't treat the pain, because if you treat the pain, they're gonna die, because pain is what's keeping the trauma patient alive. And that's hard. I mean, I dealt with a lot of, sometimes I took the limbs and put them in the cockpit of the helicopter. That's painful, but I didn't treat the pain because I thought I was gonna kill him. He says, treat the pain because it makes you human. You don't wanna see somebody screaming. It's for not just for your own psyche, but you are not going to kill them. You're gonna help them have not pain, and that's what we do, right? As anesthesia providers. Ketamine is a great, on here it's written in Hebrew, achtak, which is like a lollipop ketamine. Here, did you know, the middle picture is mine. I'm a very good photographer, so crooked. If you walk down the hallways, like you know where higher grounds is, and you see the defibrillators in the hallway, that's where that is. What else is in there? Anybody know? Sure? Yeah, Narcan. There's a stop the bleed kit. You can't see it. I was so excited when I found out that we went around as part of the trauma department and put stop the bleed kits in all the AED spots. And I was great. And then I looked, I'm like, but I can't see it. So I wanted to let you guys know, it's right on the side. It says bleeding control. So there's stop the bleed kits in there, and it has tourniquets in there. So there you go. All right, I'm gonna try to run through this sort of quickly because I wasted a lot of time there, but has anybody heard of CBRNE? Chemical, biological, radiology, nuclear, and explosive war. So you're gonna triage them a slight bit different because you have to decontaminate before they come in to the hospital. It's not something that we necessarily do. Quick rundown, chemical, so like sarin, which is what was in the Japan attack, which is a cholinergic organophosphate. Vesicants, mustard gas, which is like what we saw in World War I, so blisters and blindness, airway injury, choking agents, chlorine. And by the way, I did this to myself. Do not mix bleach and ammonia because it will kill you. It's not good. It's called choking. You get really bad pulmonary edema. And then blood agents like cyanide. So of all of these, respiratory failure is the leading cause of death. And that's where anesthesia providers, I think, come in great because we understand the chemistry behind organophosphate poisoning, right? Because we give what drug that is pretty much organophosphate? Well, we used to, now that Sugamidex has come along, neostigmine. So if you give neostigmine unchecked by glycopyrrolate, what are you gonna get? Sludge, right? So they salivate everywhere, urinate, defecate, everything sort of leaks. And then on the nicotinic side, because it's going to stimulate both sides of your acetylcholine receptor, paralysis, weakness, and hypertension. I'm not going through all this, but this is from like a military website and how to respond to all of these attacks. And so what's your antidote for organophosphate poisoning? What do you give when you give neostigmine so that you don't kill them? Glycopyrrolate. What's the other drug that you would use as an antidote? Atropine, exactly. So your priorities would obviously be to decontaminate them, antidote them, and manage their airway. And that's what this kind of shows. So you're managing the airway, you're giving your atropine. It's not just one dose, it's a higher dose, and you're kind of reassessing them. And then 2-PAM is the other antidote. If anybody's in the military, then you get that. Anesthetics that you would want to be very cautious about in somebody who's had would you give them succinylcholine? No, it's like making the problem worse, right? Would you give them a non-depolarizer? Maybe, understanding that they probably would be paralyzed for a little bit longer, so you might want to alter the dose. Would you give neosigmine? No, also making the problem worse. Ketamine and etomidate are considered safe, and using propofol to induce usually causes intense hypotension. Blister agents. So basically you get a lot of facial blistering and then internal damage to your airways. There's no antidote for that. And then it's sort of the same thing with choking agents. So chlorine gas. This is a little child in Syria because they had a nerve gas attack. You don't get immediate issues necessarily, but it can be delayed pulmonary hypertension. I'm not going to go over that. Blood agent. So cyanide is something that we can think about, because what does cyanide stop the body from doing? Being able to utilize oxygen, right? So your cells can't actually pull oxygen from your blood. So if you do a blood gas on somebody who has cyanide poisoning, what's sort of the typical thing that you would notice between a venous blood gas and an arterial blood gas? They would look the same, right? Because you have oxygen in your blood and your cells can't take it, so it stays in your venous blood. You can oxygenate in your lungs, but it's not getting into your cells. So your venous gas looks the same as your arterial gas. So essentially your venous gas is becoming arterialized. High lactic acidosis, because your cells are now in anaerobic metabolism, right? So what are you going to do about it? Obviously, you're going to give them oxygen. What's your antidote? Thought I put a slide on it. Cyanokit. So people in house fires who are enclosed in small spaces and who have smoke inhalation need to be treated in ER with Cyanokit, and that's the antidote, hydrocolloic at the bottom there. It's easier to say Cyanokit. Biological, I'm not going over because we experienced that with COVID. Radiation, there's not a whole lot from an anesthesia perspective. That's more chemical because it's airway. But what I did, if I picture myself, what would I be worried? I'd be worried about touching the patient. So basically, if they are decontaminated, most of the contaminants are on their clothing. So if that's all removed and they're showered, then they're generally considered safe. If the exposure is on the inside of their body, then like their vomit and stuff would be what you would need to be careful about. And the big thing with a radiation mass casualty incident would be that you would get a ton of contaminated patients, not necessarily injured unless it was polytrauma, come into your ER. And so now you just have a chaos that needs to be. Oh, and by the way, the farmer has the udder on his face, brown bag. I thought it was funny because I'm a farm girl. So like I said, basically the thing is decontamination with them, which is not something we would typically do in the ER. I'm not covering, I am not a nuclear physicist, but what I thought was, so I just wrote these attacks on here because I looked them up. What are the biggest nuclear attacks recently? And then when I looked this up on April 5th, it said the name of a nuclear power plant, Iran, April 5th, bomb, da, da, da. I thought, when was that? 2000, that's today. It didn't actually happen. So I don't know what to believe and what not to believe, but we have a war going on in Iran, and there are nuclear weapons sort of in that mix. So anyway, explosion. So one thing to think about this, so blast injury, the primary blast injury is going to get all your sort of air-filled cavities. So your ears, rupture your ears, blast lungs, your GI tract, there's air in there. Eye injury, head injury, probably closed. And then because the blast throws you up against something, you get the massive injury from now maybe penetrating and blunt trauma. And then the tertiary blast of other things coming in, hitting you and fracturing you and amputating you. So it's considered polytrauma, and it's high mortality along ICU. All right, so this is the last section I wanted to talk about. So as providers or people who have experienced trauma, how do you deal with it? How do you cope with it? How do you cope with it in the moment? How do you cope with it after? So this little story, short story, or question for you. So here's a situation. This was presented to me by some head psychiatrist of the military. You are a paramedic or whatever, in rescue unit, and you're in a helicopter, you go and you rescue a family, and they're out in the middle of the desert, and they've been hiking, family of 3, mother and father. And the boy, he falls and he hits his head, and now he's unconscious, he has a major head injury, call the helicopter. They decide to take the father and the son and go to the hospital, and maybe the son he might not make it, okay? Now you have the other half of the rescue unit, and they're gonna hike out with the rest of the family and the mother. And it's a hot day, it's in the middle of the desert, and you have a long hike to go. And one of the children looks at you and says, "Can I have a cup of water? Can I have some water?" What do you say? It's a long hike, it's a long day, stressful event. Of course, I'm thinking NPO, does he need surgery too? Yeah? Well, why not, right? Why not? Sure. But the answer is ask your mother. Why would you say that? Why would you say to the boy who is with the mother, she's kind of decompensating because she's worried about her son in the helicopter, she's taking, you don't want her to become another patient. You need her to stay in control. And by staying in control, she's staying in control of her children. So you need to keep her unemotional, not thinking about the other child, although she's going to be thinking about the other child, but she needs to remain in a disassociated state. She cannot be emotional because she needs to be functional and get out of this situation before decompensating. You can decompensate when you're done. Right now, you're in charge of your children. Can you have a cup of water? Ask your mother. Second one that I want to mention, this was on October 7th. These 2 little children here, they were in a kibbutz. Their village, their community was attacked by the terrorists. Everybody in their community, most of the people in their community were killed. And their parents were killed in front of them. They saw them being shot. They had a younger sister, and she ran off. So these 2 little children here, they ran into the closet. They took the phone and they called 911, Israeli 911. For 12 hours, they stayed inside the closet, and they talked to the 911 operator with the parents right outside the closet, and ongoing terrorists coming in looking for them to kill them. So the 911 operator is telling them when to be quiet. They can't cry. And then the phone starts to die. So they have to get out of the closet at some point in time and go get a battery from their dead parent's body. So if you picture yourself, you feel sorry for the children, of course. You picture yourself as the 911 operator. You go through this for 12 hours, getting through the children. You cannot let them be emotional. You have to be empathetic, but you have to keep them functional. You cannot let them cry and be a child. So the 911 operator, which is this little girl here, calls her boss, who's the one who gave me the presentation. And she went through this very, very difficult thing dealing with these children. She calls you. She's very stressed. What's the first thing that you say to her? What would you want to say to her? How do we usually greet each other daily? How are you? How are you doing? How was it? No. Because if you say that, you're eliciting emotion. She cannot yet be emotional because she needs to stay functional until she debriefs. We'll talk about this. So this is kind of a model of cognitive functional psychology, or first aid for the brain. And the idea is, if you witness a traumatic event, if you are treated too compassionately, you elicit emotion, you elicit the limbic part of your brain, you become helpless, you become passive. There's nothing I could do about it. You are now at high risk for PTSD. You don't have PTSD immediately. PTSD, like, it's years off. It's because you didn't handle the acute stress in a very, I don't want to say non-emotional, because it's emotional, but you have to keep it within perspective. Various models that we've looked at, but they're only like to debrief people, but they're for professional use only, and they actually don't work. So this model is to provide not the public and professional and first responders with the ability to help people who have witnessed a traumatic event to not go into PTSD. This is one of my last slides, almost, I promise. So what are the things that lead to PTSD? Loneliness, helplessness, I can't control my emotions, and I'm confused. So when he debriefed that girl after the 911 phone call, he had her tell her the events in order. Being in order is very important, and the facts, And then once she got all of that out, fine, how are you doing? She broke down and went to an emotional state, and there's no reversing that. And if you cannot get it out immediately before you go emotional, the whole thing becomes confusing, blown up in your head. You cannot, they recommend this debriefing has to happen within 6 hours of the event. You should not go to sleep before that, because if you go to sleep, it's like glue. So if you've misunderstood the order of events or blown it out of proportion and you go to sleep, it's now glued into your head and you can never return to what actually happened. So if you're in the middle of a stressful event, you want to elicit the amygdala, not the limbic system, so cognitive, functional, not emotional. I sound like a very cold-hearted Russian. Anyway, just Israeli. So what you want to do is you want to have cognitive communication with them. Function versus emotion. How long have you been here? How many people have you seen? Do you want to talk to your teacher first? Do you want to very, very simple, answerable things that they can answer and succeed at answering at. Giving them a challenge. I need you to go and collect so-and-so's phone number so we can call their parent for them. Give them a sense of control so they're not helpless. Commit to them. I am going to stay with you until we are out of this situation, and continuity. If you don't, say this is what happened 3 minutes ago, and now we're safe, now the event is over. If you never end the event in their mind, it will continue into PTSD. You have to create closure immediately. A little story, resilience. This is my friend Yoav. He was injured in battle. He died, and he was resuscitated. He was flown in a helicopter to come in a body bag, and he was not resuscitated. He actually came back to life. And he survived. He had shrapnel all over his body. He had a trach. He was in a coma for 2 weeks. You see him a little bit alive there. His friend was killed. He recovered in the hospital for a while, and then he got the news. It was friendly fire. He was killed by his own friends. His buddy, his closest buddy for his whole life was killed, and now he suffers because of friendly fire. So he lost his leg. He is now in the States for another amputation because they amputated it below the knee for a better prosthesis. But with the war right now in Iran, he cannot continue to get treatment, so he's here for more amputation. And his thing for recovery is to talk about it, and tell his story, and not to shut up and be quiet about it, and also to use humor. His sisters are hilarious. They're constantly making fun of him. Nothing's too serious. And then he says the biggest thing for him is family and community, to connect with other people. And then here's me with a man. His name is David. He is an older gentleman. He was in this community, and his whole community was desecrated. Same, you see the mailboxes there. The black is killed. The red is kidnapped. And he spoke to the group that I brought from here. Nancy was there. And same thing with him. He wanted to just talk about it. Just talk about what happened. Don't close up. Go on, live life, be resilient, and don't look back in anger. Because that's the most important thing. And with that, I'll say one more thing. When we were in Israel on the bus, we would do one word in Hebrew. And of course, they forgot them all, but I will leave you with one word in Hebrew. It is shalom. It means peace. And that's that. Thank you.